Hello, MedSurg students. In this presentation, I'm going to be reviewing disorders of the eyes and ears. So we're going to start with the eyes and then we'll move to the ears. So some of the structures we're going to talk about today include the lens of the eyes, because we're going to talk about cataracts, the optic nerve, because we're going to talk about glaucoma and that gets damaged in glaucoma, the macula, which gets damaged in age-related macular degeneration, and then of course the retina, which becomes damaged in diseases like diabetes, hypertension, etc. First, we're going to talk about some assessment techniques and what data collection looks like for people with eye disorders, or even people that are just having annual exams, because everybody should have an annual eye exam after 40. So this is the Snellen chart, and I'm sure you are familiar with this. It tests visual acuity, in other words, how well you can see. So you have the patient stand 20 feet from the chart. How I remember that is I'm making them stand 20 feet because I want to know if they have 20/20 vision. They probably don't, but that's just the way I remember it, okay? You're going to have them cover one eye and read from line 3. And if they can't read line 3, you'll go up to line 2 and line 1, okay? Then you do one eye and then the next eye, okay? That's how you do the Snellen chart. The next test we're going to review is an extraocular muscle test. This can be done at the bedside, fairly easy. You can hold a pen or just use your finger. Tell the patient not to move their head, only their eyes when doing this test. And basically, all you do is move in the 6 fields of gaze. So you move 6 directions to make sure the eyes are moving in each direction. And this tests the functionality of cranial nerves 3, 4, and 6. And you can remember it by cranial nerves 3, 4, and 6 make my eyes do tricks. Nystagmus is an involuntary movement of the eyes. Now, if somebody has nystagmus on a far lateral gaze, like when you're doing the extraocular muscles, that's normal. But if they have nystagmus without looking in the far lateral gaze, then that is abnormal. It's involuntary. The eyes can move sideways, up and down, or they can be moving around and around. And it can be done, it could be because of diseases like multiple sclerosis or an inner ear disease. It could be due to medications as well, because many medications are damaging to the inner ear. We'll talk about that later. Please review this slide about administering eye medication. I know you'll be practicing in the lab, but kind of visualize a step-by-step process of delivering either drops or eye ointment. Here are some abnormal eyelids variations that you may see in clinical. So the first one is ptosis at the top here. Now, ptosis can occur in older people, but if it's a normal part of aging, both eyes will have ptosis. If somebody has some neurological condition, it may just be one-sided. And the third cranial nerve helps us lift our eyebrows. So there could be damage to the third cranial nerve if there's only ptosis on one side. The bottom disorders, entropion and ectropion of the lower lid, that can happen as people age as well. So you may see that in clinical. The eye disorders I'm going to be talking about today can result in blindness. So it's very important that you care for your eyes. Wear sunglasses when you're outside. If you are diabetic, maintain tight glycemic control. Don't smoke, because smoking causes a lot of eye disorders. And make sure if you're doing sports or working in your tool shed and drilling stuff like that, make sure you're wearing eye protection. Okay, let's talk about macular degeneration. There are 2 types. I wouldn't get too hung up on the different types. I'm just going to briefly explain. One is age-related, so AMD. One is, and that's called dry, also dry macular degeneration. And there's also a wet version of macular degeneration, which can occur at any age. And as I said, age-related occurs due to advanced age. So the risk factors for macular degeneration include smoking, hypertension, diabetes. There is a hereditary link to macular degeneration. Females, diets lacking in carotene and vitamin E, and drinking 4 alcoholic drinks per day. All right, so what the client will complain of is a lack of depth perception. Objects seem distorted. They can have blurry or double vision. They'll have blind spots, usually central blindness. So I'm going to show a picture of what that looks like in a minute. And the color perception is going to dull over time. And then they'll eventually go blind. The diagnostic procedures, the physician, the optometrist, not optometrist, ophthalmologist will use an ophthalmoscope and look in the eyes, Snellen test, and that's a test of visual acuity. Those will be done. So in age-related macular degeneration, their middle vision or their central vision is damaged. So they'll have a scotoma. Scotoma means a blind spot. And as you can see, if you look at the tree, they lose that central vision. This is an Amsler grid, and it's used for people with AMD to detect if their macular degeneration is progressing. So what they will do, and you have to teach this, is they will view this grid every day to determine if they have a blind spot or if the grid is wavy or missing pieces. Okay, so that's important. The other teaching you'll do is, explain to patients that they need to eat foods high in antioxidants, vitamin E, and 12. As the loss of vision progresses, they're going to need probably support and community support, okay? Because they're not going to be able to watch TV maybe, they won't be able to drive, they won't be able to get around, so they're going to need community resources. Also, as they're progressing in this, they will need like books with large print, magnifying glasses, so assistive devices to help them see better. This is a cataract, which describes opacity of the lens in the eyes, which then impairs vision. Some of the causes you can remember from the mnemonic damaged. So diabetes, aging, myopia, which means nearsightedness, okay? So they can see near but not far. Anterior uveitis, genetic, so there's a genetic component. Electricity, so trauma. Radiation, being out in the sun too much, okay? That can cause cataracts. And certain drugs can also cause cataracts. Dexamethasone, I think you'll be learning about soon. That's a corticosteroid that can cause cataracts. Your risk factors, therefore, of cataract risk factors, you can remember by the mnemonic A, B, C, D, E. So age, advanced age, so as people age, they can get cataracts. If they be smoking, I had to use that for the mnemonic to work. So people that smoke are going to be at risk. People that use chronic use of the ABC drugs I just presented in the previous slide, diabetes, alcohol abuse, and too much sunshine. So people with cataracts are going to have an absent red reflex. That's when you take a picture and you see the red eye. That'll be absent in the eye with the cataract. They'll have blurry vision, opacity of the eye, decreased visual acuity, meaning they can't see as well, yucky night vision, meaning they can't see at night. They have trouble seeing at night and probably should not drive at night anymore. Diplopia means double vision. Decreased color perception, so they don't see color as well anymore. Increased vision loss over time and painless vision loss, and they may suffer from photophobia, especially after surgery. We're going to talk about some of the care of taking care of a post-op eye surgery patient. So patients with cataracts can have them extracted, and they would, need education on these nursing implications I'm going to be describing. But these nursing implications are the same for most eye surgeries, okay? So they need to sleep on the opposite side of their surgery. They need to be in semi-Fowler's position to decrease intraocular ocular pressure. They need to change their eye patches daily. No sex for 8 weeks. Eyes will be bloodshot. Expect itchy eyes. So that's expected after surgery. The eyes are going to be itchy. White and clear drainage is okay after surgery, but if they have yellow or green drainage, think infection. You need to report to the provider immediately if they report increased eye pain with nausea, because that could indicate that the eye is hemorrhaging and it's putting pressure, okay, and that's why they're nauseous. Okay, so anybody with eye surgery to needs not to bend at the waist. They need to bend at the knee. So if you have to pick something up off the floor, bend at the knees, not the waist. And this is all interventions to reduce intraocular pressure, okay? Because bending at the waist increases intraocular pressure. No coughing, no sneezing, no blowing your nose, no straining, which means everybody that's had eye surgery needs a stool softener and drink a lot of fluids, etc. Low sodium diet to keep the fluid down. Limit caffeine. They cannot tilt their head back, like they can't wash their hair for a time after surgery. And no activities that result in increase intracranial pressure. So really, they need to limit their head movement. Education post-surgery. Now this will be the same for any type of eye surgery. Okay, so they need to wear sunglasses outside. Everybody needs to wear sunglasses outside. Avoid getting water in your eye after the surgery. Make sure you report manifestations of infection, so yellow or green drainage. Avoid activities that increase intraocular pressure, which is bending at the waist, sneezing, coughing, blowing your nose, straining, moving your head too much, having sex. So none of that, okay? And bleeding and infection are the two main complications. All right, we're going to talk about glaucoma now. Now, what you need to know is there's two types, right? Now, both types, if they haven't been diagnosed, it's going to be an emergency to get them in to see a provider, okay? Because they need to get on medications right away. All right, so there's open angle, which is the most common type, and there's closed angle, which is not as common, but could potentially be more damaging because it happens really quickly. It's a sudden rise. Now, I don't want you to spend a lot of time trying to figure out the difference between open angle and closed angle. What I just want you to know is that what happens in glaucoma is that there is increased intraocular pressure within the eye, which presses on the optic nerve, which is then going to disturb the vision. Okay, so that's all I want you to know about the two different types. Okay, the signs and symptoms of glaucoma. Glaucoma results in tunnel vision. So people have a loss of their peripheral vision. They may feel like a curtain's coming over their eye, or they may feel like they're in a tunnel, okay? They'll have blurry or decreased vision. If their intraocular pressure is very high, okay, they may get like an eyebrow headache. That's one of the questions. Does your eyebrows hurt? And they're going to see halos, specifically rainbow halos around lights, and their eyes could be red. Warning signs that you may be developing glaucoma, including getting new glasses and not being able to see. Okay, so sometimes what happens with people with glaucoma, they'll start going like every month to get new glasses because they're not working anymore. So that should be a tip-off that you have glaucoma. They have blurred or hazy vision that clears up after a while. They're going to have trouble getting used to dark rooms. They may see rainbow-colored halos around lights, and their vision is going to narrow on one or both eyes. So encourage anybody with these to get a complete eye exam so that they can get treatment right away, because glaucoma can cause blindness. So they need to get treated as soon as they suspect they have it. Okay, so the treatment for glaucoma, you can remember from the mnemonic stamp. So put the patient in a supine position. They may be prescribed an eye drop called Timonol, which, LOL, you probably know by now, it's a beta blocker, eye drops. So eye drops can be absorbed systemically. So that might result in low BP and heart rate. So you would monitor for that. Also, you would worry about people with asthma or COPD that they might also suffer from bronchoconstriction from the beta blockers. Okay. Acetazolamide is another drug. It's a sulfa drug, so ask about a sulfa allergy. It's a carbonic anhydrase inhibitor. So it's used to decrease the intraocular pressure by reducing the aqueous humor production. Mannitol is a IV osmotic diuretic. We give it for increased intracranial pressure and increased intraocular pressure. Pilocarpine. Pilocarpine is a cholinergic medication which constricts the pupils and allows improved circulation and outflow of the aqueous humor. Okay, the next disorder we're going to talk about is retinal detachment, which happens when the retina pulls away from the blood vessels that supply the nutrients and oxygen to the eye. Okay, so the patient, it has kind of a gradual onset. All right, so the patient is going to see floaters. See right here, these black floaters, and they may also see flashes of color. Retinopathy occurs usually due to like diabetes, smoking, hypertension. It results in retinal vasospasm, and it damages those little retinal arterioles, okay, which then decreases the blood supply to the retina. So the patient is going to have blurring. They may have like blind spots in their field of vision, and they see like black lines and spots. So the treatment is tight glycemic control, frequent eye exams. You would encourage that to anybody that's diabetic. And there's some other treatments they can get as well. This is a diagram of the ear that you can review. I just want to point out that the 8th cranial nerve, this is cranial nerve 8, and this is the vesticochlear, and this helps us with balance and proprioception. And then the facial nerve, which is cranial nerve 7, is also housed in this area. In this lecture, I'm going to talk about hearing loss and conditions of the inner ear. Okay, there's many reasons for hearing loss. For example, noise, loud noises like going to concerts and sitting up front, or a musician who plays music. People that run a lot and wore earbuds for a very long time could have hearing impairments. Medications can cause damage to the 8th cranial nerve, such as aspirin, NSAIDs, aminoglycosides, furosemide, platinum-containing chemotherapy agents. Older adults can suffer from either conductive or sensorineural hearing loss. When somebody has sensorineural hearing loss, it's due to damage to cranial nerve 8. Conductive hearing loss means there's something blocking, something structural, that a provider can probably see, like too much wax, a bone spur, fluid in the ear. That's conductive. Like, in other words, they can't hear because there's something blocking the ear canal. Now, you're going to need to know what the Weber test is for. It's really important. Okay, so it's a test to determine if hearing loss is conductive versus sensorineural. I talked in another slide that conductive hear loss refers to something preventing noise through the auditory canal, okay? Whereas sensorineural hearing loss is due to damage to cranial nerve 8, all right? So with this test, a tuning fork is placed on the forehead, and how I remember that is a weather vane is placed on top of a house, not on top of your head. So that's how I kind of remember the Weber test, where the tuning fork goes, okay? So a negative test, meaning what you want to see, is hearing in both ears equally, okay? If somebody has sensorineural hearing loss, they will hear better in the unaffected ear. In other words, the ear that is not damaged if it's sensorineural hearing loss. If it's conductive hearing loss, they will hear better in the affected ear. Okay, so something is blocking the auditory canal in conductive hear loss. They will hear better in that ear. Okay, now I'm going to describe the Rinne test, which tests for bone conduction and air conduction. Which way do you hear better? In normal hearing, air conduction, meaning the noise outside, is conducted better through your ear than through bone conduction, okay? So you get the tuning fork, and first you're going to test air conduction. So does the patient hear better with air conduction or via the bone? So you would put this tuning fork then on the mastoid process, okay? So the bone right underneath the ear, okay? If they have conductive hearing loss, bone conduction is either equal or longer than air conduction, which makes sense, right? Because with conductive hear loss, there's something blocking the auditory canal. Okay, so their bone conduction hearing is better. If they have sensorineural, air conduction is better than bone conduction, so essentially like the normal conduction. Okay, the Romberg test can be done to test cranial nerve 8 as well. It's a test of balance and proprioception. Now, proprioception is a hard concept for students to understand. Proprioception allows you to know where you are in the world without looking. Okay, so like you can walk, right, without looking at your feet, and you still know where your feet are. Okay, does that make sense? So how this test is done is you take off your shoes, close your eyes, and your doctor, your provider will see how well you maintain balance. If you start to sway, that's a positive Romberg test, okay? So there's all kinds of variations on it, and you'll do it with your eyes open and then your eyes closed. When you take 120 next semester, you're going to learn about otitis media and middle ear disorders, okay? Inner ear disorders, we're going to talk about a little bit, can result in tinnitus. So if somebody took too much aspirin, they might get tinnitus. Vertigo, vomiting, nystagmus, like we talked about earlier, and alterations in balance. Okay, if somebody is suffering from vertigo, okay, they need to restrict the movement of the head because that's going to stimulate their 8th cranial nerve. Change position slowly, decrease sodium and caffeine and alcohol in the diet. Fluids need to be spaced out evenly throughout the day because it can be because of fluid in the ear, okay? They need to rest in quiet, darkened environments, so that may help their symptoms. These medications help with vertigo. One thing I want to say about being on these medications, in addition to having vertigo, which the patient should always be on fall precautions. All right, that concludes our presentation. Please review how to administer ear medication.